Okay, welcome to this afternoon's session on leg ulcers. You're very welcome. If I can just tell you all to switch off your mobile phones or put them to silent, and to fasten your seatbelts for a 90-minute clinical leg ulcer journey of your lifetime with some excellent speakers this afternoon. And the first person I'd like to invite to the stage is Professor Andrea Nelson from Leeds University, who is going to tell us about Betty and her leg ulcer and tackling unwarranted variation in care from Betty and her leg ulcer. Thank you.
Thank you very much. What an introduction. Follow that. So I'm starting off this session with quite a sort of policy-oriented example. But what I'm going to do is hopefully provide you with an example of how we need to use different types of information and convincing narratives in order to think about change. So this is about Betty and the concept of unwarranted variation in care. It's part of a national approach to reducing unwarranted variation in care led by the NHS in England. So apologies for those of you for whom the word national means something different than England. But I hope that this will still be useful. We're particularly interested in using this approach to reducing unwarranted variation in care as a way of giving an example of how nursing in particular can lead change and add value. And the NHS has developed what it calls a right care approach, which some of you, if you've been around a long time, might recognise in things like getting the right care to the right person at the right time. However, I think this framework that builds upon the leading change, adding value notion for nursing and midwifery leadership is very helpful for us to frame how we might go about being real leaders in organisational behaviour change. And we all in this room have a part to play, regardless of our role. In essence, the NHS right care approach, which will be presented in more depth tomorrow afternoon, has some principles about getting everybody to be talking about a real burning issue, and we're talking about wounds, fantastic, leg ulcers, even better, fabulous. Get everyone enthused and talking about something which is a real big problem in care, and then addressing what is it that needs to change. So we're going to present what may be some uncomfortable truths about what needs to change, and you may have a cringe if you recognise some of the things that have happened in the environment that you work in or have worked in the past. And then it will move on to how do we effect change. Underpinning this is the very simple mantra, if you always do what you've always done, you'll always get what you've always got. So we know that pressures on all of us are increasing, so we need to change how we're delivering care. The slides which you can see today, which have the NHS Right Care logo in the top right-hand side, are all lifted from the slide pack, which is freely available on the web, and I'll put a link to it, so that you can download these and use them in discussion with your partners, with your commissioners, with colleagues back at the ranch. But in this scenario, we're going to look at Betty having a great time and Betty having suboptimal care, and making these journeys for patients personal is incredibly powerful, and I'm delighted that we have a real person taking us through that journey after me, so he'll steal my thunder totally. But it's also about talking the language not only of patients but of commissioners. For example, does it make a difference to the quality of care, to the outcomes and to the costs? And yes, it does. And in box 2 here on the slide, you'll see that in this work we've also modelled the costs of care to the Commissioner, so that people can have a conversation about the implications of unwarranted variation in care on healthcare systems and all of our participants. So Betty may be familiar to many of you. I hope that by deriving a general history of Betty, that you will see that we've used somebody who is not that unusual. She's got arthritis, she's a bit overweight, BMI 30, and she's had a recent health check when she was 70, and both her and the practice nurse agreed that it was very difficult to lose weight when you get to our age. So they had a little chat about that, but hadn't really got the appetite for anything more to happen. Shortly after her health check, she went on her normal rambling club trip, rambling sort of the C group she would be in, the bit of a dawdle, but very important for psychosocial health. And she injured herself and only identified that when her tights were sticking to her leg. Now, the two paths in the woods that Betty could have taken, the rambling club trip to there or the rambling club to there, are diverging. And we're going to look at her suboptimal treatment pathway and something which hopefully would be what we would be striving towards. In her suboptimal pathway, in this theoretical example, this may not have all happened to the same person in your experience, but she goes to the pharmacist first, who keeps on selling her dressings because she's looking after it herself. And eventually the pharmacist says, perhaps go to the GP. The GP prescribes antibiotics, sees her a couple of times, eventually passes it on to the practice nurse. The practice nurse hasn't had any particular support in developing their skills in leg ulcer care, but knows really well that you don't apply compression bandaging to something that looks like a leg ulcer if you don't know what you're doing. So there's a very conservative care package put in. There's a growing impact on Betty's life in terms of she can't go to Aquafit anymore with the dressings on, so she stops going to the lunches, becomes more withdrawn. The treatment pathway goes on, and eventually there is referral to somebody who can do a Doppler, who confirms there is venous disease there. Bandaging's applied to control the swelling, but her mobility has reduced over all this time because she's been getting more withdrawn. The reduced mobility, her pain has increased in her knee, and she's called for her knee replacement, and it's delayed due to her having a leg ulcer. Does this sound familiar to anybody in the room? There's a few very discreet nods, bless you. And the practice nurse calls in for the community team help. They're very, very, very stretched across the patch, and eventually manage to help and with the practice nurse develop a plan of care which includes compression, building up the confidence of everybody involved that this is the right treatment for Betty. And after a period where she's had some daily visits and gets an infection and gets admitted to hospital for some cellulitis, eventually she ends up with a healed leg ulcer after 18 months or so, and gets knee surgery at 2 months. So there's significant things that we can measure when we're looking at patients such as Betty, using the global data that we have through commissioning groups, for example. So Betty, in her suboptimal pathway, will not only have incurred greater costs to the NHS and poorer use of resources, but very importantly had a much poorer outcome and poorer care experience. And the exemplars that we have around the costs of compression bandaging are just one example of the size of the variation in care. So you can spend 90,000 per 100,000 population on compression bandaging, or you can spend what looks to be like £1.50. And there's Bassett Law in the middle. Anyone from Bassett Law here? You're right in the middle. Hey, hello. So what we'd like to do is to have more of our care looking like good and very good, and having less of it having low utilisation of compression or high utilisation of beds. So for example, this is a similar snapshot of CCG data on non-elective admissions for bed days, so for lower limb ulcers. So all of these unwarranted variations in care, they all come together to increase costs, increase the use of resources. But I don't want to leave you on a downer. I'm now going to take you to that other path in the woods that Betty could have taken. Remember, she could have had optimal care, and I'm very pleased that you will see some grains of recognition in the story that I tell you now. It's a story where, at her health check, prevention becomes part of the conversation, because there's a conversation about getting more active and keeping, for example, going to the rambling club, reducing weight, reducing the risk of turning that red, itchy skin on your ankle into an ulcer. And whenever the ankle's swollen, support for compression through hosiery, for example, is implemented early doors. There's, after the injury, prompt referral from the pharmacist to the GP and thence to the practice nurse, who's got a quick access into the community nursing team to check what the plan of care should be and how to deliver that optimally, and radically do things like have double length visits for a Doppler assessment. You know, how innovative do you have to be to get that? So there's a leg ulcer clinic locally. They can access that for further assessment if needed. And Betty can get into a routine of self-care where she's able to feel more like her again. So she can have a shower, she can take compression hosiery off, because she's able to graduate very quickly through multi-layer bandaging into compression hose. So Betty feels more like myself again, and the commissioning groups have a much lower cost. So at the top of the slide, the difference in the modelled cost of care between optimal and suboptimal care is tenfold. £5,000 per treatment or 500. So Betty's leg ulcer care could have taken a pathway that missed opportunities for optimal care, or she can have a pathway where opportunities for optimal care are maximised. But this requires not only individual action, it also requires actions as teams and as commissioning groups. And I'm hopeful that those of you today here who are nurses or midwives are familiar with the leading change, adding value model as a way of saying it's for us to start leading that change, adding the value and using tools such as Betty in order to make our voice heard. Thank you very much.
Are there any questions on the floor? No? Oh yeah, just one over there.
I was interested you were keeping the same model of care with your nurses. I thought I was trying to...
Well, you have a loud voice.
Yeah, but obviously, come click on. You had the same model of care provision, and I thought the evidence from any of the sort of manufacturing, the more processes you have, the more chance of mistakes happening. You know, and I wonder whether you should be the pharmacy is giving out hosiery to people quickly.
That's a great question, Richard. And actually, with you asking that question, I think that this description of optimal isn't actually, there isn't ever an optimal that we need to stop with. There are probably multiple optimals for different settings and for different people. And this is not optimal for everybody. There might be reasons why we would actually intervene with pharmacists first off, That's a really great suggestion. I'll take that back.
Okay, thank you.
Thank you.